Good evening, Burke County. How are you? All right, I'm going to make the assumption that you're out there because with these lights I can't see. But I'm going to welcome you anyway to a wonderful evening here at the Comma. I'm Michelle Mathis, and I'm the Executive Director and co-founder of Olive Branch Ministry. We are a harm reduction agency that serves Burke County. I want to give a special acknowledgement to any elected officials that we have in the audience tonight. We thank you for being here, for taking time out of your schedules to come to hear a report about what's happening here in Burke County. And I want to thank everyone else as well, because we know that we all have busy lives, but we know this topic of substance use disorder and serving the citizens of Burke County is something that is important to everyone in this space. Olive Branch currently serves around 200 individuals through funding and from the Dogwood Foundation and in partnership with Burke County Public Health. We are fortunate that Dogwood and Public Health both believe that harm reduction is part of the recovery continuum, and we will continue to do this work as long as we possibly can because we believe in the health of Burke County, and we know that there's always opportunities for positive change. So I'm going to be quiet now and turn the mic over to UNC Health Blue Ridge President and CEO Gary Paxson. Mr. Paxson.
Thanks, Michelle. Good evening, everyone. It's my privilege to welcome you, all of you, to this important community forum. We gather here today, I believe, with a shared commitment to education, discussing and finding solutions that strengthen our communities and support those impacted by addiction. Before we begin, allow me to introduce myself. For those of you who've never met, my name is Gary Paxson, and it is my honor to serve as the President and CEO of UNC Health Blue Ridge. At UNC Health Blue Ridge, we are deeply committed to fostering health and healing within our community. Addressing substance use disorder is a critical part of that mission. And tonight's discussion is an opportunity to explore meaningful solutions that can make a real difference. Substance use disorder is a challenge that affects families, workplaces, entire communities, and addressing it requires collaboration, compassion, and evidence-based approaches. Tonight, we have the incredible opportunity to engage with two distinguished leaders in this field, Governor Ernie Fletcher and Dr. Kathy Colville, who bring years of expertise and dedication to the conversation. Dr. Colville, Associate Dean for Community Engagement and Outreach at the University of North Carolina, Chapel Hill of Social Work, has built a career in the intersection of policy, healthcare, and social impact. Her leadership continues to bring academic research with real-world solutions. Dr. Fletcher, former governor of the state of Kentucky and founder of the Fletcher Group, has spent his career advocating for addiction recovery through housing, healthcare, and employment opportunities. His work has transformed how rural communities approach recovery, creating sustainable ecosystems of support. It is my pleasure to welcome back to Burke County and to the Comma stage, Dr. Kathy Colville and honored guest, Governor Fletcher.
All right. Really excited for the chance to be here. Thank you so much to Gary for that wonderful introduction and to Reverend Mathis. I do know that you can see the screens over here, but I want to make sure that we also thank Dogwood Health Trust, Comma, Olive Branch Ministry, and the amazing people at Burke County Public Health who've put an incredible day for us together. We're really grateful that you all are here tonight, and we also know that there are people watching on streaming now and will be watching later, so we welcome everyone to the event today. And we also want to give a really special thank you to our American Sign Language interpreter. Thank you for that applause. All right, so I'm going to give you a little bit of a sense of the format of our forum, and then we're going to go right into it. You can see the information up here, which tells you to email your questions. So if you have a phone with you, you can go ahead and put that email address in there, and that's the way that you can send questions up to our moderators, and they're going to put the questions up here on this screen for us. We'll get to your questions after a while. We're going to have a chance to get to know Governor Fletcher a little bit better, but we want to make sure that you understand that we welcome your questions and comments, and we'll have a really nice time for some good dialogue. All right, we ready to go?
We're ready to go.
Sounds good. All right, so I might surprise you a little bit. I'm going to start with a joke. All right, so I'm gonna need to make sure I get all this correct. So, a saxophone player, a mechanical engineer, an Air Force captain, a family physician, a Baptist lay minister, a 3-term U.S. Congress member, a Kentucky governor, and a healthcare CEO walk into a bar. Now that sounds like kind of a crowded bar, doesn't it?
That it does.
But it turns out that that's all one guy. And that is Ernest Lee Fletcher, who has held all of those roles over history. So I'm just going to repeat that again. All-state saxophone player back in high school, right? I don't know if you still play the sax, but I thought that was a cool
I try a little
thing.
bit.
You undergrad at University of Kentucky, and that was the mechanical engineering, is that correct? Okay. Then you go into the Air Force, and you became a captain in the Air Force, and I want to ask you a question about that a little bit later. After that comes medical school back in Kentucky, family physician, get into the ministry, then politics, and now you are founder of the Fletcher Group, working throughout the entire United States. So really, that is all one guy.
Yeah, I have trouble keeping a job.
Yeah, exactly. So there's stories to each of those transitions, I'm sure. We're going to talk a lot today about what you're doing now, but I thought that was a really interesting aspect of what you bring to this work. That's a lot of really different experiences, and one of them that I want to just know a little bit more about is the Air Force captain. I read a little bit about that. You were in Alaska in the late 70s, is that right?
That's correct.
And you're like, basically, you and the Soviets are keeping each other in line. So tell us a little bit about that.
Okay, Kathy, yeah, that was, I was 20-some, and wife and I, we were, married actually before I graduated from college, and went to pilot training, and I got signed to fly an F-4. Now, it's an old fighter, a Phantom's what it's called, and they've all been retired since then. But I was deployed or assigned to Alaskan Air Command, where we set air defense alert. It was during the Cold War. Jimmy Carter was president at that time. And so we'd have a lot of cat and mouse type games with the Soviet Union. They would we were on what's called NORAD and the DEW line, the distant early warning line. And so we defended, the continental United States up at that point. And the Soviets would often launch a lot of electronic intelligence planes to come in and see how far they could penetrate our airspace and fly over our land. And so I spent about a total of 1 out of 3 years setting air defense alert there. And I think we would get intercepted. They would call us and launch us, and we'd go out and intercept the Soviet aircraft and come up close to them and escort them back home. A lot of exciting times of that. One thing I think I came away and I had a wonderful sense of there is after sometimes we'd be launched, and it was in the winter, the sun didn't set up there because we were flying north of Nome. And, we would come and intercept some of these Soviet aircraft, turned around, and we had a whole infrastructure there out of Cheyenne Mountain in Colorado that were directing us. And when we get back, I just realized even one thing, that 20-some-year-olds defend our nation. And you think about that, they're flying these machines now that are so complicated and so capable. And we turned that responsibility over to some 20-year-olds, rightly so. I mean, maybe the oldest guy I flew with there, maybe in his mid-30s at that point.
Yeah, so was your nickname Maverick or Goose or, I don't know, that's just...
Well, I'll have to tell a story. I became known as Boom Boom.
Okay, that's good. Well, the first new piece of information, boom, boom.
I didn't put that in the bio, but I dropped down into a gunnery range and sped it up, and I tried to fly about 0.95 Mach by the range tower. And unfortunately, at all of that particular weather, barometric pressure and everything, I was really doing about 1.2 or 1.1. So I end up moving the range, blowing all the windows out and everything else. And so that's where I acquired the name of Boom Boom.
That's excellent. So troublemaker is what we're talking about.
I was a troublemaker. Yeah. I was 20-some. What could I say?
Yeah, so this is an interesting thing to go back and read about these different things. Boom Boom did not come up in my research, so I'm glad to know that. But, the part of the thing was with all that, are you Dr. Fletcher? Are you Reverend Fletcher? Are you Captain Fletcher? Are you Governor Fletcher, right? There's a lot of different hats that you've worn. And I guess when I look at that list of the different, each of those pretty intense experiences. And I think this is someone who has a large intellect, who has curiousness. It seems like you want to know stuff and learn about it. Sense of adventure, for sure. An appetite for risk. Some restlessness, I see in that as well. And also, as we talked about, an independent streak, right? That runs through all of that. But I want to ask you, just as you think about the through lines and what connects and some core values and commitments, like what do you think has remained true through all of those different parts of your life, all of those different experiences? Or what commitments do you feel like you can look back at that kid in All-State Band and the healthcare CEO and say, that's the same person?
Well, like all of you and all of us, I think we evolve. Probably the essence of us doesn't change, but, we evolve. I think adventure was probably part of it, just looking at new things to do and the excitement of it. And my wife has kind of sometimes tortuously followed me through all that, and she's had her own career as well. But I think the biggest part is that we're raised in a family, and it was important to kind of give back and serve your community. Probably didn't have anything to do with me playing the saxophone. I just enjoyed doing that. But and it's interesting you say that, because one of the goals I would have had was to be a professional saxophone player, but I was never quite that good. Mm-hmm. Mm-hmm. And so maybe that's why I jumped from job to job. I was never quite that good.
Well, you got time. You got some time left. That could be job number 12, okay. Right?
The other thing, later on in life, I think my faith driving. I told somebody asked me why I did this when I was in Vermont, and we were doing a town hall, and I said, look, it's serving the least of these. Mm-hmm. My a colleague of mine, a family physician colleague, he called them LOMBs, least of these my brethren. And so we had a little thing that where we were serving, we would take ER call for folks that didn't have health insurance, and it was always to serve the least of these. And I think that's important, and I know there's a lot of folks we've met with in the community that may not articulate it that way, but that's where your heart is and what you're doing.
Mm-hmm. And I can see the connection back to the kid, Boom Boom,
yeah.
Defending the country, and that connection to that sense of service and the idea. I think you mentioned the Matthew 25 concept yesterday as
right.
being a guiding light for you. So you leave the Air Force, you go to medical school, you start to get into lay ministry, and then you start to get interested in politics. And one of the things I was sharing outside is that what I've admired about watching you operate yesterday and today is that you have a clear understanding of the importance of political leaders the politics of this kind of work, but you don't politicize the work. But I want to go back to this, just how you decided to run for office for the first time. What made you decide to do that? And why did this feel like a place where you wanted to take that spirit of service and adventure?
Well, I'll have to say I really never planned on being in politics. I mean, we had always a debate around the kitchen table about politics, so I guess I had a little bit of training from that, but I never saw myself as really involved in politics. But I told this to the med students today. I had a patient, and she gave me all the permission to say names, but it was, and she was a single mom, and Olivia was her daughter. And I took a few of those patients that I would kind of especially adopt, so I spent a lot of time with her trying to help at least direct her on how to raise. Olivia didn't have a male figure in her life because the father had left. And I tried to get, after Olivia got into school, I talked to, her mother, Sharon. I said, Sharon, let's talk about your career now. Mm-hmm. And she was on, age-dependent, anyway, it was welfare basically, and in Medicaid. And she said, I can't get a job because I'll lose all my benefits and I won't even be able to take care of Olivia. And I said, really? Mm-hmm. I was very naive. And so I started getting involved in politics and said, that's crazy. Why would anyone have a system that would lock somebody into dependency and not allow them to be all they can be? I was just doing it behind the scenes, and finally somebody talked me into it, and we agreed to do it, and just took off from there.
I promise for people that we aren't going to dwell on the politics piece of this, but I do want to make sure people understand that you do have an extensive elected official background. You were first in the Kentucky General Assembly, then U.S. Congress, then you served as governor. And when you were the governor of Kentucky, you were the first Republican governor in decades to serve. That was around 2003, 3 terms in Congress, and so on. And I want to talk a little bit about that time. So we're now fast forwarding to 2003, your term as governor of Kentucky. I want to ask you a little bit of what you all were noticing at that time in terms of substance use disorder. What was going on in Kentucky? What were the pressing concerns? What were you trying to do? Yeah,
I had in my, I was practicing family medicine at that time and ended up serving as, they asked me to serve as a CEO for their foundation to support practices. So I was doing that at that time when I ran first time. But at that point, I really encountered the problem of addiction. It wasn't near the epidemic it is now, but I'd had some experience with it at that point. When 2003, 2004, when we really started doing a lot of the work on addiction, methamphetamine was the drug of choice, and it was home-cooked stuff, not the pure and potent stuff we're seeing come in from Mexico now. But it was that, and just looking at the devastation it was causing, particularly eastern Kentucky, which is very similar in culture in Appalachia to where we are today. And the devastation it had on the communities and things. And I had already worked with a recovery house in Kentucky called the Hope Center. I'd done a homeless experience too. They asked, the Chamber of Commerce did a project where we were supposed to just live 24 hours as homeless. And I was a member of Congress at that time, and I remember we were out one night, it was cold. They gave us a blanket and a few other things, but we didn't have much. And we were camped out in the park that night, and I met a guy by the name of Harvey. Now, Harvey was a homeless individual, and he sat down with us, and we visited him night, and we were all freezing, so we built a little fire in the city park. I guess they didn't arrest us because they knew what we were doing, but we were freezing to death. And it gave me a little bit of insight to what a homeless individual goes. But I talked with Harvey, and Harvey sat down, and he pulled out 2 things. He pulled out a Bible and a bottle of vodka. And I began to realize the conflict and the power of addiction that it has. That here, Harvey wanted to get his life back in order, and he had worked construction and everything, so we talked about his life. But he was so consumed with alcoholism and the alcohol use disorder that he couldn't do it. And that really made a big impression in my life because it impacted his family. He was homeless, all these things. And then the next day I got up in the morning and I was a bit disheveled looking by that time. And near the end of the 24 hours, I was a fairly well-known congressman, but I walked down the street and the people wouldn't look me in the eye because I looked like a homeless person at that point. And that kind of awakened me again.
How interesting. So both getting to know Harvey, but also that people wouldn't look at you.
Yeah, just having to walk, and it only took 24 hours. That's what blew me away.
Interesting. So let's talk a little bit about where that went, that empathy building and that starting to understand this is a more complex project or more complex problem than just saying, Harvey, go fix yourself, right? Yeah. There's more to it. You started to work with Don and Myra Ball.
Right.
Construction fortune, wonderful philanthropic, well-known family in Kentucky that did a lot in terms of, I think it was mostly residential construction that they did, or?
Yes, they were
building homes all
builders,
over.
Yeah. And they built some, lower income housing. They built some other stuff too, but they were really into helping entry-level homes build.
So tell us a little bit just about them as people.
Yeah.
What what kind of people were they? And what did you all do together as you started to work on this issue?
Don and Myra Ball were just two wonderful people, and we'll go back to the history of how they met, but they had developed a company called Ball Homes, and they'd been very successful, worked very hard. And Don had served in the General Assembly for 1 or 2 terms, and he decided that direct politics wasn't what he needed to be doing. But he was involved politically. I mean, he would have they end up having a large horse farm and house, and they did a lot of political events. So he was very helpful in my campaign, and Don never really ever wanted anything for himself. But his primary interest was, he said, nobody cares about the homeless. And that was his approach. I mean, it was a broad statement and maybe hyperbolic, but it was in large part true, especially back, you go back 20 and 30 years ago. And so he had supported building these centers. And when I got elected, Don asked me for something. And actually, he was such an individual well known in the community. I would have, appointed him whatever he wanted just because he was going to do an excellent job and he had a wonderful reputation. He said, I want to get on the Kentucky Housing Board. And I thought, why not chair the UK Board of Trustees or something prestigious?
He could have asked you for a lot more, is what you're saying.
Yeah. I said, Don, it's yours, go on there. And he told me what he wanted to do, so I knew it was a good idea. Well, he came to me with this plan, and I'd worked with him on the Hope Center and Chrysalis House and gotten some grants out of Congress for them. So I'd already worked with him. He said, I want to build these centers all the way across Kentucky because they address the homeless, the folks that have been incarcerated. They turn lives around. The outcomes are great. And I said, Don, put together a plan and bring it to me. And he did. And he ended up chairing the Kentucky Housing Corporation, brought that to me, and he wanted to build, I remember, 11 centers at that point. We ended up building 14 eventually. And everybody in my administration said, well, we need to cut that back to 6. And I said, no, if Don wants to do 11, we're going to do 11. And brilliant financier, he put together the finance for him and everything. And the other thing that it did is that in the 4 years we couldn't complete building all those, but the next governor was a Democrat governor, and his wife, Jane Beshear, was Steve Beshear, took up that mantle and really supported it. So it was a bipartisan effort, and we get along great with them, and that continued on to finish out that. So. And Don since has passed away, but he and Myra were just very well respected in the community.
So this was Recovery Kentucky.
Yes.
And can you tell us just what it would be like to be someone who was using the services of Recovery Kentucky? What was there? What was it like? And
Well, it's
what are those centers?
each center will accommodate 100, sometimes 100 to 120 individuals. They're all in recovery, and a lot of them had generally had their lives very disrupted. They weren't low, they were high acuity folks with SUD, so they were needed residential. And what we did, and Don worked with we worked together to bring down the silos. So we had our basically HHS, called Health and Families, and we brought our Department of Corrections together. We brought our Housing Corporation together, and Justice Cabinet as well. And what we did was build this where folks could come get paroled and go into these. So about 60% of the beds we held for corrections. And these were folks that we turned around, and they spend anywhere from 6 to 24 months in those. And it is a complete curriculum where they focus on recovery only. I say that, but part of recovery is getting ready for employment and getting out and reentry into the community. And we've got 13 years of data outcomes done by the University of Kentucky Center of Alcohol and Drug Research. And the centers really, and I had nothing to do with this, it was after a model, really there's outcomes that match or exceed anyone in the country. And it's because it helps these folks rebuild their lives and give them the confidence and the connection back and the loving compassion they need.
So you're doing this work as governor. The next governor, Democrat, takes on and continues that work. And at some point, you and Don Ball start to talk about taking this national and scaling this a little bit larger than that. So tell us about that evolution from Recovery Kentucky, which, looking back on everything that you've done, this doesn't seem out of character, but it seems like the first time you've been working specifically on substance use disorder and everything, and then now that has become your life's work.
Yeah, it is. Don and I were at a UK football game, and if you've been to many, I hate to say it, many UK football games, it's not always a positive outcome. So we got talking about other things, and he was there, and they had a box, of course, and so we were there, and he was talking. He said, Ernie, I really want to talk to you about taking what we've done nationally. And he said, I'd like to have your help. And I said, Don, whatever you need. I've got a not-for-profit. We were working in foster care and some other things as part of our business down in Atlanta, or aside from that. And I said, I'll be glad to help you. So, and that was probably 10 years ago. And so I met with him a few times, and he said, Ernie, I'm really serious about this. Let's do it. And I said, okay. So we called, I brought down the Secretary of HUD, I got the governor, we got everybody at his house and met, and everybody was positive. And then Don was going to do this, I was going to help him. Well, he got ill, and he came to me, and he said, Ernie, I can't do this. You've got to do it. I said, well, Don, I've got other things I'm doing. And he goes, no, we'll do it. So he passes away, and I talked to Myra. And so I tell you, it wasn't all my altruism, but I did say, okay, if we're going to do this, we've got to have some resources to do it. And I wasn't talking about it for me personally, but so I called Myra and said, Myra, you want to do this, we need to raise some money. And I went back to my team, and we put together some finances and said, if we want to get this off the ground, I said, I really, we're going to need about $1 million. So she calls me the next day and said, I'll write you a check for $1 million, whatever do you need? What else do you need? I said, Myra, that wasn't the answer I really wanted at that time. I was hoping to scare you away. And it's, I've got a CEO that was our interim CEO, and he's been the interim CEO for 7 years now, so I guess you call him a permanent CEO. He's got about 40 years of experience in all this stuff, and I had to learn a lot, but we dug into it. And Kathy, one thing, this has taken off as well or better than any effort of anything I've done. It is just we've gotten such traction, and we've got a marvelous team and culture. Kristen is here with us, and a lot of other folks have lived experience, and they just bring a wealth of experience and passion to what we're doing.
And passion, right? And
Yeah.
commitment. I think that is just such a amazing part of getting to spend time with your team, both in the preparation for this and then in person over the last couple days. Let's talk about the recovery ecosystem. You talked about that. You built the Recovery Kentucky Centers to be a place where people could get access to treatment, but also many other things. You know, a lot of us think that the outcomes for individuals is based on that person. Are they strong enough, right? Are they committed? Do they have enough faith? Sometimes in the back of our heads, we have this concept of bad apples, right?
Yeah.
And the recovery ecosystem is something that just feels, from the beginning, has been an important part of the work that you've put together. I want to make sure that people know what part of what your work has done is to work with another research group out of University of Chicago to put together the Recovery Ecosystem Index. So if you haven't looked at that, Google that. It's a free thing for everyone to look at their own community related to that. These are the factors in a community, not in a person, that support recovery from substance use disorder. And I'm just going to give a little bit more and then ask you to talk about what it looks like in practice. So when you look at that index, you'll see things about, is there access to substance use disorder treatment? Is there a continuum of support, like case management, peer support, housing, education, and so on? And what about the infrastructure and the social factors? Employment, housing, transit, social support, all those things are part of that index and that understanding of recovery ecosystem. I want to understand why that's an emphasis for you, what the outcomes are related to that, how that person factors and community factors kind of interact in that recovery ecosystem. And a little bit, again, about what is it like to actually be a person who is in recovery in a very, very highly functional recovery ecosystem. What kind of supports are there? What kind of things is that person doing?
Well, it's a good question, and as I think about going back, one thing that occurred to me, and I read had some businesses, so I read a bit of Peter Drucker, who's kind of a guru of business, probably the early guru of business. And he had a statement that anybody that's run business who probably knows this, that culture will eat strategy's lunch any day.
That's a good one, yeah.
And so, I started thinking about that, and we did, and I said, well, it's the culture in the community has a tremendous impact. And no matter what strategy you put together, if the culture in the community is not conducive to some compassionate care, it's going to be an uphill battle. And so we started looking at, what does a community look like in that? And I think obviously sometimes, and not always, but the reflection of, there's a lot of factors that go into it, but if a community has a lot of providers that step out, if its stigma is lower in a community, if they support them with health-related social needs or social drivers, and that means that you got to get down into, when people come out of prison, some of the first things they need is an ID. We don't think about that. Mm-hmm. But you have to get down into the details, and are those kind of support services there? Because without that ID, they can't get a job, they can't do anything. Some of them have, lost it for one reason or another, their driver's license. So, and you're talking about things that keep people from really being all they can be. And so it's not only is there a provider there to treatment, but is there the transportation? Are the employers open to hiring them? Are the court systems looking at more for folks that are not a public safety risk? Are they looking at really transforming those lives and getting them the treatment they need so they don't see this revolving door. And that's part of that ecosystem. And then, you start to look at other things like transportation, childcare, et cetera. But all of those things are needed for our lives. And most of us are pretty capable of searching them out. But somebody in recovery, and let me say this, when they're in I'll say the jaws of addiction, their brain is not functioning properly. You can't expect them to go out and make those decisions that some people expect them to make. Why don't you just do this or that?
It seems so easy, right?
And
the right decision, right?
It does, but you all probably, most of you here have an interest, so you understand that.
Yeah.
But they are so captured by that addiction that they cannot make those decisions. And so you have to have those support things around them. And you have to make it accessible. You can't give them a slip of paper and say, go here and do that.
Sure. Yeah.
You've got to engage them, and I think a timely engagement is very important. And it may take a little while. In our programs, we have kind of a transitionary and motivational phase so they can get their head cleared a bit, and so they can understand, because at first they may not want or even comprehend what recovery might do for them. But as they go through that stage, then they begin to understand, hey, there may be light at the end of this tunnel. There may be some hope. And so I think it's important for that. And then a longer term treatment. This is not an acute disease. It's a chronic disease that requires a long-term approach.
Yeah, and that change is so hard, right? And nuance, there's all of this ambivalence about whether people want to, this is tough situation. Part of what I heard you talking about and part of what I've learned about the Fletcher Group is that there's an approach to developing meaningful, purposeful work and employability, and that there's hope in that and meaning that comes out of that. And you told us a story yesterday that I'll ask you to tell again today, or just about how the work is, how you've worked with employers to do the, I think you call it the fair chance employers concept, and employers that would otherwise be very, very concerned potentially about working with people that are in recovery, hiring those folks, especially if there's stuff in the criminal background that comes up, how you've built those relationships, what you see as a part, so how you've worked with the employers, the transformation that you've seen through access to meaningful work. And then I think you've shared a little bit too about what kind of the employers are getting out of this as well, what's happening for them.
In most communities, and I was involved a lot when I was in public office with economic development, and when I was looking at recovery, I say this is a win-win. One, for the community, because you get some very good, skilled employees with some life experiences. Now, some of them may not be one that we would ever want to go through, but they've had some life experiences, and that brings a good level of maturity in a lot of ways. Now, the population, if they're supported well, become more productive workers than the individual walking off the street. The other thing, when you talk to employers, they already have a good percentage of their employees already have substance use disorder. It may be 10, 20% sometimes, maybe not quite that high, but they already have probably SUD or diagnosis. And so they already have those there, and a lot of them, and I know even as an early employer, I was in healthcare, so we had to be very careful, but I'll have to say, years ago when I was an employer, I wasn't very tolerant. When I had somebody show up with alcohol in their breath, that was it. And we had no remedial program for them, anything. And when we started working with employers, we said, one, they've got a need. And two, we can do the testing, the training, and the support for these individuals to fulfill their need. And we collaborate with colleges or educational institutions to make sure they first get their GED, and then they may get some certificate, and we align that with employer needs. And then we test the individuals to make sure it's of interest to them. Because part of what and we were talking about, the importance for recovery is a measure we use, it's a measure of resiliency. It's called recovery capital. And it's really a measure, the higher their recovery capital, the less apt they are during periods of stress of reusing or relapsing. And so it's a measure of how strong their recovery is, if you will, put it in another term. And meaningful employment is a big component. It builds a tremendous amount of recovery capital in an individual. And especially if you get them in the job that is meaningful to them, they enjoy it. Part of recovery is giving back. An important part is connection. And jobs, employment that is meaningful brings that. Interesting, the last few things that Don Ball said to me, he said, you know, one of the weaknesses in Recovery Kentucky, we don't do enough to get people into meaningful employment. And we thought about that a lot, and we've done programs. We've got another program we're waiting for things to a 6-state project on doing exactly that, working with providers and recovery houses and providers to say, hey, you want to help build recovery in that individual, let us work with you to explore their career and explore the job opportunities and work to bring that meaning and purpose in their life. We all need that. I mean, and so that's been very effective. And then we've transitioned. I'm going to tell a quick story.
Yeah.
We worked with a guy named Ben Taylor. Tailor-made farms. They're thoroughbreds. They can do more than golf clubs. But anyway, tailor-made farms. He wanted to do some programs. So we worked with him to bring folks in recovery to, first off, just be elite. We called them elite groomers because we would train them how to groom horses. And these are the most expensive horses in the world. So we're dealing with some very high-end horses that, you entrust to people. And so we started that program, and it's not just for them to groom or muck stalls or things like that. It allows them to move up to become farm managers and trainers and all kinds of things within the thoroughbred racing industry and the farming industry in toto there. But there was a film done of after about a year of the program, and there was one of the individuals in recovery, and he rides this horse around. They can allow him to train him in the morning. So you can realize the trust that Ben and his team had on these individuals to allow him to ride these, multi-million-dollar horses. But then when he got off the horse and he was kind of patting it on the horse, and I don't remember the horse's name, but he said, he finally trusts me. And it was just very touching to me because it's working in addiction, you realize that a problem that a lot of folks, and for good reason, the folks in addiction recovery have to develop a trust of people around them because oftentimes they've experienced trauma and they've experienced things that would make them no longer trust a lot of individuals. But that bonding to there, and that was so healing for that individual. And we've had just a wonderful experience. And that's just one of the employment lines that we've worked on.
Mm-hmm. I love that example. We had a question earlier today about sort of what leads people down, understanding what leads people towards addiction, and you talked about trauma and lack of trust. And I remember thinking during that question that a lot of the things that you are talking about on the other side as part of recovery, like employment and housing and social support and education and transportation, are in fact also the same things that are protective against developing substance use disorder in the first place. Now, we don't think of that because we often are thinking of that individual level piece, but that's such a great example of meaningful employment creating this psychological trust that helps, and that concept of recovery capital that you mentioned. It's like you're banking this good housing and this good job and those pieces that are helping people to, manage the very real demands that come from addiction, right?
Yeah. And the support they need, and I think it has a preventative effect, whether it's maybe more secondary than primary prevention for those that deal with epidemiology. But the fact is that a culture within a community that is supportive, it doesn't mean that there's a difference between, and there was actually the head of the College of Public Health out of Brown University did a research project where if communities are close and they provide support, but they understand and the culture there is that, hey, smoking is not good for you, et cetera. But the community is close and develop a supportive community, that the incidence of smoking is much lower. And so community culture has a tremendous impact. And I think as you're developing that recovery ecosystem, you're inherently working in primary prevention as well. Because young people, as you know, little pitchers have big ears, as we used to say about our kids. Be careful what you say around them. But they understand and hear that and pick up on that culture very quickly. And then when it's a culture of compassion and trust and support, I think that has an inherent prevention.
And opportunity creation, right?
Absolutely.
I think that's a big piece of this. So let's talk a little bit about housing, because another big aspect of that recovery capital is housing. And housing's expensive. And there are some people that would say housing is a person or a family's responsibility, right? But you're saying a really critical part of the model that you're putting together is thinking about housing. And you've got a couple of different ways, the level 3 or the level 2 and so on. So can you just kind of elaborate on us why housing is so critical?
Yeah, we're also end up being a center of excellence HUD for recovery housing. And part of that, the effort is to integrate healthcare into housing. But the flip side of that is housing is healthcare. Okay. And I use this as maybe a silly illustration, but if you got a diabetic on insulin that needs refrigeration, try treating that individual that's living under a bridge.
Sure.
It's that's the last thing they're thinking of. They have many other problems.
Sure. Yeah.
So and from a conservative, politically conservative, and I am, and I think that the investment in that we can show pays off. So it's not, wasting taxpayers' dollar to provide the kind of recovery housing that individuals need. It actually turns their lives around. It makes them productive taxpayers in the community. It promotes business and economic development within your community. It makes your community safer. Every aspect is improved. So yes, housing is extremely important. And when communities come together, it's challenging. It gets more challenging with the inflation that we've seen in housing prices. But when a community comes together, they can afford it. And I think if they're really interested in growing, they can't afford not to.
I appreciate that. And I'm going to quote you from yesterday. You said you have to have all the links in that chain of the full continuum of care in order to get all the benefit. You can get benefit here and there, but it's really having all the links in that chain together to get that full return on investment. So just help us to know, what is that full continuum of care? Like, what are all those elements?
Well, I may leave out some because and I think most of you will inherently know it, but think about what you need in your life. If housing, primary, you can't really function and do stuff. I mean, some people are very resilient and live out of their car for a while, but chronic homelessness is it generally takes its toll on folks. Second, a supportive environment for that individual, a recovery environment is important. And I'm looking at folks' recovery. Now, what does that mean? That means that you have to have, first off, the housing officials in the county or government to be able to support that. If financially you want to be able to afford it, you've got to leverage those federal funds for that. Two, if you've got to have the educational facilities, and I'm assuming, leave out providers as important, they're obviously essential. When you have your providers and recovery providers and your peer support, all of that are important. But you have to have the educational institutions, because you can't turn somebody out of a recovery house on a minimum wage job and have them expect to stay in recovery. Few might be able to do it, but most of them will find that they're going to be homeless fairly quickly, because that's not a wage that they can live on. And also they're going to find that, hey, this is just too tough. I'll go back to the way I was. And so having that education that can move into a meaningful employment is important. But early on, they've got to have transportation. And if it's a single mom, they've got to have childcare. And if you start looking at all of those things, and I've left out probably several, but you all know them, all the elements that you accept because you've put those together in your own lives of everyday life. And one of those links, if I'm in recovery and I can't get to my job, and I lose my job, and I lose the apartment I'm in, and I'm back out on the street, it's a good chance you're going to relapse. It's just the way it is.
Gotcha. It makes, thank you for playing it out like that, or helping us to see that. It's a lot though, right? That continuum of care.
You know, and Kathy, let me say this. All of that stuff is in your community. The hard part is linking it together and accessing it and having a pathway that works for people to access it.
I think that's a really good point, right? We're not building from nothing here, right?
That's right.
And we would often say we feel that that's inadequate, many of those things, and yet I think what you're also saying, and this is kind of the point that I wanted to do, is that you're not building the continuum of care in the richest places in the United States. You are doing this in Middlesboro, Kentucky, in Somerset, Kentucky. And if you're not from Kentucky, these are places that have a lot in common with places like Burke County and around, right? Like, these are places that are not just flush with resources, but they're figuring out how to put these things together.
You know, they are, and we had a ribbon cutting or opening for Middlesboro, what we call ROAR, Recovery, Hope, Opportunity, and Resilience. And it's kind of just in summary, it's a full continuum care, from clinical detox all the way to we have scholar houses, and it was built for pregnant and parenting women. And a few comments we got at the opening. First off, the judge executive came out that had been a judge executive. He was a conservative judge executive, and he came out and he said, "I've done a lot of projects in my 20 years here," and he said, "And this is the most important project I've ever done for my community."
Wow.
We had 2 drug court judges that came out and just said, "Thank God I've got a place where I can send my women that I know they're going to get care that come in courts, because there's no other place anywhere close that I can get the kind of support you want." And that's the impact that I think it has, and you begin to build that hope and culture within the community. Now, we had to work, and there was a lot of late evening calls, I'll say, where, some NIMBYism had come up, and
Sure.
the housing authority didn't want to give the Section 8 vouchers or something, and we had to continue to work and not give up. But we've got that facility now, and it's changing lives.
Thank you. And this is not where you're just turning to Myra Ball and saying, write me a check, right? You all are being very creative about how to fund these projects. So if you can share a little bit about pulling from here and how you've done that.
By the way, that was about 7 years ago, and I still think we have half of that money. Okay. But we've been very fortunate. We've been able to get a number of grants and do some contracting work, and we've just got some wonderful staff. But I just think as you're beginning to look at this, don't some of the smaller communities there's advantages and disadvantages of small, close communities. One, everybody knows what everybody's doing. And so you have to be very aware of NIMBYism because it's a tight community. And we've had projects, I mentioned one in Eastern Oregon, where we had the funding and everything, and I'll share the kind of the funding we do. And it fell apart at the end when we had a public meeting and some very, anyway, hostile people came out, even with guns, and said, you're not going to bring those people from Portland, Oregon in, which was never part of our plan. And they shut the whole project down. So I think building that community support from the very beginning is essential. So that, and having the elected officials understand everything, be very supportive, and your community leaders being very supportive. So when you get that pushback, you're able to stand and to resist it, and resist it in a way that is appropriate. And I think you can change the hearts of those individuals eventually. You know, we use all kinds of funding. We've got opioid abatement money now that's available and you can leverage. Interesting, I've got a neighbor that wanted to volunteer. He wanted to answer the phone. Well, he happened to be a major investment banker in London and Wall Street. I said, you don't need to answer the phone, and we answer our own phones. But I said, how about let's find some investors that want to do this. So he worked for a few months, and he said, call me Ernie, I got this group out of Wall Street. They've done over $1 billion in housing, and they'll put up $100 million for projects, and all they want is a small interest rate, but they want a secure principal, so they're not looking like a hedge fund. And we're still yet to use that, and I throw that out because I think there's some money that, if you be creative, there's some money in this opioid money that you can leverage money of the future of opioid abate money by current money, and it really makes financially a lot of sense because of building costs going up, et cetera. We use low-income housing tax credits. We built all of our 14 centers debt-free. We use low-income housing tax monies. There's something called a federal home loan and savings banks, and they come along. They have some philanthropic responsibilities, and generally we would get $500,000 or $1 million from them as long as you got the LIHTC. We would also use some EDA grants, Economic Development Area grants. We got that in Richmond, Kentucky on one. You start looking at foundations, and you all have got some wonderful foundations around here. So be creative and look at that. And then there's some philanthropic things, so community support. But you've got to get your operational costs covered as well. And that's a little more difficult because if you're going to amortize or if you're going to get the capital investment, you've got to show you've got, you know, the operational revenue coming in to support that. And we had to do that through corrections. We did it through SNAP and food stamps. We did it through CDBG. We did it, you know, the corrections, it was a big part of that. And we do it through project-based HUD vouchers. So that's, but we have to be creative. We've got a guy of finance who's a Harvard MBA in this stuff. So he helps us put, you know, that funding together, and it's possible. You just got to keep turning over every rock you can.
I appreciate that. And we'll go back to that example that you talked about with Eastern Oregon, where part of the message from the folks who were so against it was those people, right? It's a those people message.
It was.
And the those people message is not the Matthew 25 message. Nonetheless, the those people message is very powerful. And one of those people that you all are intimately connected to is people who have been incarcerated, sometimes for very serious crimes, sometimes for very long amounts of time. I want to ask you a little bit, this is another quote from you, "It's stupid to lock up people whose lives can be transformed." So let's talk a little bit about your the relationship between your work, the recovery model, and the criminal justice system.
I didn't realize I was so frank earlier today.
Yes.
Let me say it's not wise for a couple of reasons. One, for human capital and the interest and compassion for humanity, or the dignity of humanity. I want to say something. I learned something from I'm going to get back to the criminal justice, but I was practicing medicine, and we used to take care of folks that had no doctor. So I had a guy one night come in, he had to totally, I didn't think he would live because he had infarcted his bowel, and then he was a homeless guy, just in horrible shape. But I had a wonderful surgeon I got a hold of, who was probably the best in the state. He was trained in Vanderbilt, but that's another story. But anyway, came in and operated on him. He survived, so we kept seeing him, but we never could get him really out of the homeless. And frankly, I didn't have the resources to do that. I would take care of him if I could get him in my office, I would. So I probably failed on really trying to move him beyond that. But he came in one night, and Charlie Sachatella was the surgeon. He saw him one night, and he admitted him. And I saw him the next morning, and I looked through all of his labs and everything, and he had no reason that we could put in order to get reimbursement, because we'd gotten him on Medicaid, for the admission. His labs were all okay. He was in horrible shape, but x-rays, everything did not meet a criteria for admitting him. And Charlie Sachatella wrote across the ER thing, admitted for the dignity of man. And that still brings tears to my eyes, because I just think that, in the hospital, he was obviously a critical part of the hospital, and we had a big practice there. And, they weren't going to stop that at that point. But we've got to realize that no matter how low an individual has been beaten down or whatever in their life, and we don't know, they still have the same dignity of man that each of us carry because of that. And I think if you look at those individuals that are caught in the jaws of addiction, and yes, they've done some things, and they need to be accountable when they've done things, because I think our society wouldn't hold together if it didn't. But you've got those folks that can get into a recovery program and can really turn their lives and have very full, meaningful lives. And we've got story after story of individuals. I was down at St. Matthew's in Naples, and a young gal gave her story, and I've heard probably hundreds of them, but she was a gal that got caught into human trafficking, sexual trafficking, everything else you can imagine in her addiction in life. And she got just so low, and the, I call them pimps, had taken advantage of her in every way they could. And she came into the St. Matthew's place down there and turned her life around. And now she's got a master's degree, she's married, she's got kids, and you just don't know. And yet, if somebody hadn't given that young lady a chance, she'd probably either be dead or still be in that horrible existence. And that's when you look at an individual that's coming in, even to the criminal justice system. Can we do something different? Because in the long run, you are going to improve public safety by transforming that life.
Thank you. Thank you. We're going to move to some of the questions from our audience. We've got a first one for you that kind of goes on the themes that you were just sharing. Asking you to share a success story from the Fletcher Group that illustrates effective support for someone overcoming homelessness.
I can't, I'm sorry I can't remember the individual's name, but there's a couple that we had, and this has been a few years ago, I spoke at a Chamber of Commerce meeting and they wanted some discussion on addiction, and I think it was toward fair chance employment as well. And I brought in a couple that had been through our facilities and things, and both of them had been in recovery, and both of them had a life that was just totally destroyed. Both of them had been involved in the criminal justice system, and both of them have been involved in homelessness. And homelessness, as I told the story of Harvey, is just takes a terrible toll on people. And my 24-hour experience was nothing compared to what these people go through. And I always knew at the end of the day I was going to go back home and get my feet warm and be fine. But a big driver of homelessness is addiction, and if you can turn that around, and this couple just had a beautiful marriage now. They were working in recovery for folks, and they already had had a child at that time. And you just see that kind of transformation from somebody that's living on the street and has no hope to coming around and having a fulfilled life and really understanding what love is all about.
Yeah, wonderful. So the route from before to after comes through the treatment access, sometimes medication access, the employment, the education, the housing, and all of those pieces, right? All of that continuum of care.
You know, Kathy, some people are capable, and depending on the acuity of going through recovery and don't need quite as many support services. But when you're talking to individuals that often get involved multiple times in the criminal justice system or become homeless, you know the impairment of their life has been at a higher level, or what we call a higher acuity of disease at that point. And those are the individuals that really need that full continuum of care. And any weak link in that chain is going to make the whole thing ineffective, or at least less effective. So I think it's important from there. First off, you can't treat them if you don't keep them alive. So, you know, the naloxone, the harm reduction or risk reduction efforts are essential. And, you know, policymakers have focused a lot on that, and I think that's important. But I also see that they're moving beyond that and not lessening the import of that, but realizing that, and we had there's a state we worked in, New Hampshire, where they had a decrease of 15% in overdose deaths, but they had an increase in non-fatal overdose. And what that tells you is that they were doing a great job for harm reduction, but they were not transforming lives, because these people were maybe overdosing more, but they were given naloxone and recovered. So I think it's important. You've got to have harm reduction. So the full continuum of care is important. You've got to save their lives. Medication is important, and it varies. Every pathway to recovery that I've seen, and I've come through it myself. I'm a recovering politician, so I do say that is different and unique. And one of the things I've seen, at least from an observer outside of not being in recovery, is that a lot of times folks in recovery have a successful pathway, and they think that's the pathway for everyone else. But folks that have worked in the field understand that every person is unique and every pathway is unique. So they may need not all of that recovery ecosystem, but some do. And some will need parts, all will need parts of it.
I appreciate that. We had a question on here as well that went to the policy level. It was they're flipping around questions here right now, but it was a question about policies that you've seen work well, what policies have you seen work well in other states or communities that North Carolina might consider adopting?
Well, I think there's a couple of things that come into mind that we're working on. One is looking at, we have reimbursement for clinical care, but we don't have good reimbursement for social recovery models and for peer support service that takes that individual beyond that acute phase. And I think looking at some alternative payment methods that are not complicated, that recovery houses can implement and provide that revenue that they need, because in our financial analysis, you can keep an individual for 6 months in a social recovery model for what it takes 30 days in the clinical model. And I'm not trying to pose one against another. I'm trying to say that you can get that 6 months. The clinical care is taken care of, and that's important, obviously necessary, but you can get that 6 months for a lot less, and you have a lot less relapse or reuse in 6 months than you do in a 30-day program or 28 or whatever it is. So I think looking at alternative payment methods for social recovery is important, and that will help support the development, along with making sure they have a good certification, or looking at outcomes that you require from recovery houses to make sure you're getting evidence-based programs. Thirdly, I think looking at more criminal justice diversion and deflection, and a good program. We worked with Measure 110 out of Oregon, and they had a program where they just basically gave a civil ticket to somebody that had possession and said, you know, you don't have to pay the fine if you go into treatment. Well, that didn't work because it had no teeth in it. But they came back. We're running a deflection program where there's an agreement with the prosecutor, the judge, and the individual that's arrested said, hey, you agree to get into the treatment and we won't incarcerate you. And we kind of help coordinate that program for the state of Kentucky now. And I think that's something that the states can look at, is running those deflection diversion programs at a more comprehensive level than what they're doing.
Thank
That's just
you.
a few things. There's other I could go through a litany of them. There's landlord laws and fair housing laws and all kinds of things.
Yeah, there's a lot when you're getting in housing, isn't there? We'll come to perhaps a final question in just a second, but one of the things we haven't talked about, which I know is critical to your model, is peer support. Yeah. So please share a little bit more about, you know, in what places and what areas are you incorporating peer support, and why do you find that to be an important aspect?
A lot of the social recovery model is completely run by peer support, and these are people with lived experience. Now, in our ROAR model, or Recovery Kentucky, we'll often have folks that go through the program, and maybe they'll go through a couple of phases that we've got, but at the end of that, they will stay and become part of they're part of the therapy, okay?
Sure.
And they've instantly got respect and trust by those individuals because they've been through the program and know. And you put it bluntly, you can't BS peer support. You can't BS peer support. Look, I've been there. I've been where you are. I understand. But and we've got another project we're doing for HRSA is developing more peer support specialists and professionalizing that, because I think it's important, because they need training. They need to be certified so that they have a certain level of training. But they can also support in hospitals and medical clinics. There's programs to put them in the ER, so if somebody comes in an overdose, they can turn that over to peer support that can connect them. And a peer support can stay connected with the community and all those links of the chain we talked about to get them hooked up. So it's recognized by ASAM, the American Society of Addiction Medicine, which I participate in. They recognize the importance in clinical medicine of having peer supports within the clinic as well.
Thank you for that. All right, I'm just going to look out and see if is my timing right that we're moving to the final question now. Okay, and this is one that we talked about a little bit before. So this is overwhelming, and this is complex. And as you've said, this is an issue that you were looking at in 2003 and 2004, and this is an issue that you're looking at in 2025. You've spent a lot of time with people in Morganton, Burke County, and the region around here, both in the past and the work with Fletcher Group, but also in person today. I wanted to ask you if there's anything that you saw today that you feel like, oh yeah, like this is gonna work, like some hopeful, some inspiring things that you've seen here locally, and just what kind of gives you hope overall when you are thinking about this issue?
I've got to meet a number of the folks here, and it's encouraging. This is a group of Burke County and the surrounding counties, the 12 counties we work with. It's very encouraging because they know there's a lot of challenges to face, internal and external. But they're still willing to get out there. And Michelle that came out and introduced is doing a work, and she had to do it underground for years. But I think it's that passion and perseverance of you all within the community that are here that instills the hope that we've got. Because as I say, we'll come and help her get out of the way. But you have got a community and leaders here that are passionate about this. They see the problem, and they're going to dig and get the right solutions. They may not be perfect, and you can't wait for that, but they're going to get some right solutions, and you're going to implement it. And that's going to change lives, and it's going to change your community. And that, to me, is worth getting up for.
Yeah, absolutely, absolutely. Can we show our appreciation for Governor Fletcher and the Fletcher Group, for our interpreter, for our team from Burke County Public Health bringing us here tonight. Thank you all so much for a wonderful evening. Thank you, Governor.
Well, thank you all.